Thank you for joining today's webinar from around the globe. It's a pleasure to see so many people joining. Just to let you know that being a webinar, you won't be able to speak during the webinar, but what we would like you to do is to encourage you to use the chat function, introduce yourselves, raise questions that you may have during the professor's talk and then the following discussion, and we'll see, time permitting, if we can answer your questions. So this is a collaboration, and as Leukemia Care, we're pleased to be able to host this event with the CLL Advocates Network. This event is for an audience around the globe. We understand that English might not be everybody's first language, so we will try to speak clearly and to keep things understandable. We are assuming that everybody will have some knowledge of CLL, either as patients or as advocates. But what we would like to say is, if you're unsure about something, please ask a question. But what we won't be able to do is the doctors, the professors, the advocates won't be able to answer any questions that are specific to your own health matters. Topical questions, please, if you can. If you're unsure about information, you want more information about specific topics, if you're in the UK, please refer to Contact Leukemia Care. We can provide you with information, or visit the website for information booklets. If you're in other parts of the world, if you don't know who to access to get more information, contact the CLL Advocates Network. The website address is on one of the slides. This session is recorded, so you'll be able to revisit all of the wealth of information you're going to receive today, and there will be a lot of it. And some of the slides probably you will need to revisit. But if, for example, if you're in another country and you're not sure how to get more specific information about CLL that will suit you, then if you visit the CLL Advocates Network website, we have a global resource hub there that will actually help you find information in your own country, who provides the support and where to turn to. So without further ado, this webinar is to introduce to you the latest developments in 2022 that were announced at leading hematological conferences, at the European Hematology Association conference, and the one that towards the end of the year in December that highlights probably everything, the American Society of Hematology conference. I'm Nick, and I'm here today in my role as a Leukemia Care patient advocate as part of our patient advocacy team. Although I do have a connection to CLL myself, I am also a patient, and I'm also a member of the steering committee of CLL Advocates Network. So maybe I can take this opportunity to introduce you to our esteemed panelists, both doctors, one patient, an esteemed professor. So perhaps first, Brian, could you introduce yourself to everybody?
Hello, it's nice to see some familiar names. I'm Dr. Brian Koffman, and I'm a CLL patient myself since 2005. I'm also a retired family doctor. I'm the co-founder, executive vice president of the CLL Society, and very proud to sit on the steering committee of the CLL Advocates Network with Nick and others.
Paolo, please introduce yourself.
Yes, thank you for the invitation. I'm Paolo Ghia. I'm professor of medical oncology in Milano at Università Vita-Salute San Raffaele, where I'm directing the CLL program. And on top of that, I'm also president of the European Research Initiative on CLL, ERIC, which is an international body now that is really, I think, providing help also to patients and to physicians in order to define the best procedure to manage our patients.
Thank you, Paolo. I just remember there was one thing that, with regards to housekeeping, that I forgot to mention. If you're here in Zoom, please use the chat to post any questions. But we have colleagues working in the back room for those that may be on Facebook, just to let everyone know that this session's also being streamed live to Facebook. So if you're a Facebook watcher, post any questions you may have in the discussion below the video on Facebook, and my colleague will wing them over to us, and time permitting, we will hopefully be able to address your questions. So I think with this only being a 60-minute webinar, Paolo, would you like to share your slides and commence your talk?
Yes, indeed. And here we go. I hope you see my slides.
Perfect.
Confirm. Perfect. Wonderful. And so as anticipated, I will be trying to drive you through the last advancement that we heard and we saw at the meetings during 2022, and in particular in the American Society of Hematology meeting, ASH, last December. And I will try also to summarize the key points and see what is really changing in our practice, so what is really meaningful for the patients. And these are my disclosures. And I just want to make a quick summary of where we are standing at the moment. I think that the most important advancement that we observed in the past 10 years now is the fact that we have introduced chemo-free treatment in the management of our patients with CLL. And in particular, two classes of drugs have now become pillars of the treatment. On one side, the BTK inhibitors, and on the other side, the BCL2 inhibitors. For the BTK inhibitors, as we will see, there are many more now, more generation of drugs. For the BCL2 inhibitors, we have at the moment only one drug, but more are coming. And indeed, we saw some preliminary data at ASH, at the ASH Congress in December. And so maybe next year we will be talking about more mature data. And also, just to be quick on this, we also saw works depicting the future of CLL. So new class of drugs are coming to CLL, and in particular the BTK degraders and bispecific antibodies that have been already shown a lot of efficacy in other lymphomas and leukemias. And again, we saw the first preliminary data with these new drugs in CLL, but again, they are too premature to really affect the life of our patient. So again, it's probably something that we will be discussing more in the future next year. So having said that, I think that we could even conclude all our seminar today with this slide, not because this is work that I presented, but because it summarizes really what changed in the past 10 years for our patients. So we show that for patients with CLL and more than 65 years of age, now we can expect an overall survival which is identical, superimposable to that of healthy individuals with the same age. And this is the picture on the left, where you don't see differences in the survival curves of patients and the healthy individuals. On the other side, we also show that overall all patients with CLL can achieve the same result, but at the moment we are studying and trying to see if also that applies to the young patients, so those below 65 years of age. This is anyhow a big success, meaning that we have been able, thanks to the chemo-free treatment, to really prolong the life and the survival of our patients. Still, we are not curing the disease. We are taking care of the disease. We are definitely taking care very well of the disease. I think the tolerability of the new drugs is much better than chemo-free, much better than chemotherapy. But still, we are working, and research is working to achieve cure, definitive cure of the disease. So I just want to remind you that those results that have been obtained with an overall survival that is identical to healthy individuals has been due to the use of the continuous treatment with BTK inhibitors. In particular, ibrutinib is the one for which we have the longest follow-up and the one that showed that impressive result. And we previously presented also the data of the initial study, the RESONATE-2 study, comparing ibrutinib monotherapy, oral therapy, compared to chlorambucil, that was the chemotherapy typically used for the elderly patient with CLL. And we have been able to obtain these striking results even in patients with the p53 aberrations, deletion 17p, mutations in the p53 genes that are known as were known to be markers of poor prognosis for our patients. That was true in the era of immunochemotherapy, where indeed patients with such aberration were not responding to the chemotherapy, while instead with novel therapies, BTK inhibitors, here data from ibrutinib, we are able to achieve a progression-free survival of almost 80%. So after 4 years of treatment, 4 out of 5 patients are still responding to the therapy, and 9 out of 10 are still alive. So impressive results compared to immunochemotherapy. We have even longer follow-up with another study run at NIH, where we have that at 6 years, 61% of these patients, so almost 2/3 of the patients, are still free of progression. Of course, these are still drugs. Ibrutinib, the BTK inhibitors, much better tolerated than chemoimmunotherapy, but still with adverse events, in particular affecting the heart, the cardiovascular system. And I want the first message is anyhow that if we look at the adverse events during the first year of treatment, so here in green, and we look at those in deep purple, those during the 7th year of treatment, then we do see just at a glance that the adverse events overall tend to decrease with time. So this is the first important information. The adverse event can occur. They typically occur in the first 6-12 months, but then with time, they tend to disappear. And if a patient remains on therapy, we always say among physicians, if the patient remains on therapy for 2 or 3 years, very likely will not experience adverse events later on. But what we learn with the ibrutinib is that BTK inhibitors can be associated with an increase of hypertension, of high blood pressure, where there is an increase of atrial fibrillation, that is an alteration of the heart rate, and also the risk of bleeding in general. Though minor bleeding are not clinically relevant, the one that we should pay attention to are those major hemorrhage, which are luckily rare, and again, they tend to disappear, or they tend not to appear in the years after more years of treatment. So, but for this reason, 2nd and 3rd generation of BTK inhibitors have been developed, and I refer, and probably many of you know, the other 2 molecules, which is acalabrutinib and zanubrutinib. If you look at these red dots, just to show you that the lower number of the dots, in theory, the more tolerable is the drug, because it means that the drug is not affecting many molecules inside a cell. And with the acalabrutinib, has been, these are data presented during EHA, so the European Hematology Association meeting Congress in June. Acalabrutinib plus obinutuzumab, so plus the anti-CD20 antibody, it was compared to chlorambucil plus obinutuzumab, that is, again, an old traditional classic immunotherapeutic treatment. 5 years of follow-up have been presented, and the data are also very impressive. So 2/3 of the patient, 2/4 of the patient, 3/4, almost 75% of the patient are not progressing, so are responding when using acalabrutinib alone. And even more impressive, when acalabrutinib is associated with obinutuzumab, so the anti-CD20 antibody, there is even a much higher frequency of percentage of patients who are responding after 5 years of follow-up. And this is true also in patients with p53 aberration. So again, roughly 70-75% of the patients are still responding after 5 years, though here we don't see any advantage in adding the antibody. Another molecule is zanubrutinib, as mentioned earlier. This was compared to bendamustine plus rituximab in first line. And again, it shows that the zanubrutinib oral therapy, continuous therapy, is better than chemoimmunotherapy. And again, in patients with deletion 17p, we have an impressive result of 90% of the patients still free of response after 2 years here the follow-up is much shorter, but it's very promising for the durability of the result. But what is now the question is how all these different BTK inhibitors, ibrutinib, acalabrutinib, zanubrutinib, compare to each other, and we learn about this in the ELEVATE-RR, relapsed refractory study, where acalabrutinib was compared to ibrutinib, and this was in a very selected patient population, so-called high-risk patient population with deletion 17p and or deletion 11q, another marker of poor response to immunochemotherapy. So here they show that ibrutinib and acalabrutinib have the same progression-free survival, so they have the same efficacy. But what was important is to show that acalabrutinib has less adverse events, or the adverse events are less frequent when using acalabrutinib, in particular atrial fibrillation, as you can see here, and also in particular hypertension, where less than half of the cases have hypertension compared to ibrutinib, and also the bleeding events in general, though the minor are less, though the major bleeding remain more or less the same. With acalabrutinib also there is less arthralgia or myalgia, which are the pain in the muscles or in the joints that can happen typically after 2 or 3 years of treatment with ibrutinib. And here I just show you that indeed what it shows here is that through time, atrial fibrillation with acalabrutinib tend to occur at a much lower frequency. We have to remember also that atrial fibrillation is something that can occur by age. So it is much more frequent in the elderly population, regardless the use of acalabrutinib or ibrutinib, and regardless having CLL. So it's something that can occur at a certain frequency in the elderly population. As much as the high blood pressure, here you see that with ibrutinib it is much more frequent, especially at the beginning, while instead with acalabrutinib is much more less frequent. Zanubrutinib has been compared, and this has been presented and was a highlight of the ASH Congress in 2022 in December, was presented by Jennifer Brown. Zanubrutinib was compared to ibrutinib in all patients with relapsed refractory disease, and here the data that were presented show that zanubrutinib appears to be more effective than ibrutinib, 80% compared to 67%. Of patients still responding after 2 years of follow-up. So again, a short follow-up, one would probably desire to see a longer follow-up, a different population from the one of the previous study. This is all patients with CLL. And what they also show that the higher efficacy was even more impressive in patients with P53 aberrations, as you can see here, where only a little bit more than half were still responding after 24 months, compared to three quarters when using zanubrutinib. Of course, one has to see how this data compare to previous knowledge. With ibrutinib, I show you before that in past studies, ibrutinib was able to control the disease in P53 patients in up to 4 years with almost 80% of patients. So it might also depend on the patient that have been enrolled in this study. So this we need more data, more follow-up to really understand how this is durable and maintained with time. But anyhow, also zanubrutinib as a second-generation BTK inhibitor shows to be better tolerated than ibrutinib, and in particular in terms of cardiac adverse events, and in particular in terms of atrial fibrillation. Again, you can see here that the atrial fibrillation rate is much atrial fibrillation is much less frequent with zanubrutinib compared to ibrutinib in the red line. There is no difference in terms of hypertension, and there is no difference in terms also of hemorrhagic risk. Then there is the third generation BTK inhibitor. We already learned about these in the past years, in the past couple of years. We have two molecules, nemtabrutinib, pirtobrutinib. They have a slightly different mechanism of action compared to the first and second generation. They are so-called reversible inhibitors, so they don't stick to the molecule, but they somehow can move apart, so that might affect the persistence of the inhibition with time. So there is an indication that might have a more prolonged action, but this has to be, of course, confirmed by clinical data. At the moment, both molecules have been tested in the relapsed refractory setting, and we showed that the data at ASH, and Anthony Mato was the one presenting, so in the Congress in December 2022. And here we show the pirtobrutinib in CLL has been used in patients who have been previously treated with another BTK inhibitor. So that was really the key point. So patients who relapse under BTK inhibitors, still we are using another BTK inhibitor, and indeed, as I'm going to show, patients are responding. Interestingly, 3/4 of the patients really progressed under the previous BTK inhibitor, so they were really refractory to the previous molecule. And here's the data, which are very impressive. This has been an updated analysis. We are talking about hundreds of patients now treated, and we have an impressive overall response of 82%, 79%, so around 80% of patients responding, patients who relapsed to a previous BTK inhibitor, and some of them also received a BCL2 inhibitor, so they really somehow used all their viable options, and still they could be salvaged by the use of pirtobrutinib. And in terms of safety, it appears again as a third generation molecule to be safe, well tolerated, and probably much better even the second generation BTK inhibitors. You can see that the frequency of adverse events, in particular grade 3, is really very, very low. And in particular, when we look at the traditional BTK related adverse events like hemorrhage, hypertension, atrial fibrillation, we can see that the numbers, the frequency is very, very low. We can see a little bit of neutropenia. This is also something that was characteristic of zanubrutinib. So this might be a new type of adverse event that we are gonna see with the use of BTK inhibitors. Acalabrutinib is characterized, for example, by headache that is transient, typically in the first 2-3 weeks, but again, is something a little bit different from what we were used when using ibrutinib. Another study that we presented was the use of pirtobrutinib in patients with Richter transformation, so what is luckily an infrequent transformation evolution of CLL, but very aggressive, and for which there is no standard therapy at the moment. And here we are talking about almost 70% of 70 patients, and still we do see a response in 52% of the patients. So half of the patients responded. These are patients who typically do not respond even to immunochemotherapy. Here with the monotherapy, oral therapy, chemo-free, 50% of them responded. And of course, the length of response, the duration of response is definitely short. We don't expect we can control long-term such an aggressive disease with one therapy only, but this is very promising. First of all, because it has been used as a bridge to allotransplant for patients who were young enough and have a donor to go through the transplant. And in particular, we can think in the future to combine with other molecules, with other chemo-free drugs, and try to make it more durable and prolonged. The other molecule, as I mentioned, is nemtabrutinib, the other third generation BTK inhibitor. Nemtabrutinib is a little bit behind in terms of development, and we have only a handful of patients, say 38 patients, and but still these patients also have been exposed to BTK inhibitors before. Some have a mutation in the BTK, some don't, but still we have almost 60% of patients responding, and those who respond have a median duration that is median duration response that is around 2 years, and therefore again another very promising molecule for our patient. Again, if we look at the safety profile, if we look at the grade 3 or more, so the more severe adverse events, they tend to be very, very rare. And so this again, another molecule for which we hope to see more data, more patient treated, but that's another option that we might have in the future. So continuous versus fixed duration, that's the question that we are asking now. So now we are able to obtain durable responses with BTK inhibitors. I show you 10 years of follow-up and patient having the same overall survival with BTK inhibitors as a healthy population. But of course, we want to decrease the quantity of drugs that we give to our patient. We want to decrease the length of treatment. And this one because, of course, if with a fixed duration, we would limit also the adverse events, and we would reduce the pressure on the leukemic cells, so we would limit the evolution of the disease, and we, of course, we will also decrease financial cost. All the combination so for fixed duration, we all planned to use combination of drugs, and all these combination include venetoclax, so the BCL2 inhibitors, because with that molecule we are able to achieve very deep responses, even so-called minimal residual disease negative situations. And the combination that is approved in many countries around the world is venetoclax plus obinutuzumab, so the anti-CD20 antibody. The CLL14 from the German CLL study group has been the one that showed a great efficacy of the combination, comparing venetoclax plus obinutuzumab given for 12 months, 1 year of venetoclax, 6 months obinutuzumab, the first 6 months, and was compared again to chlorambucil plus obinutuzumab. And here is the overall progression-free survival at 5 years of follow-up. 2/3 of the patients are still responding, which is impressive, which means that with 1 year only of treatment for 4 years, the vast majority of patients, 2/3 of the patients, are still responding. So very little drug and still a very prolonged response. There are some issues if we look at patients with high-risk disease, in particular those with p53 aberration. This is the blue curve here, and the patient with the p53 aberration reached a median progression-free survival at 49 months. So it means that 50% of the patients progressed after roughly 4 years, which means 1 year of treatment and 3 years free of treatment, which probably seems a little bit too short for this particular high-risk population compared to what we can achieve with BTK inhibitors, where after 7 years, we have still 2/3 of the patients responding. For the patient with unmutated immunoglobulin genes, who is another population which is at high risk, though better risk compared to the p53, also here we reach a median progression-free survival of 64 months, which means 1 year of treatment and 4 years of treatment for half of the patient without progression, which is indeed a very interesting result. Maybe still a little bit shorter than with BTK inhibitors, but still very comparable, in particular thinking about the better tolerability of the drug when given with the fixed duration. And this is indeed shown in this slide, where, of course, during treatment, you might have a number of adverse events with venetoclax and obinutuzumab. It is well known that patients can have neutropenia, febrile neutropenia, infection that tend to be not so frequent if we compare to neutropenia. In the era of immunochemotherapy, neutropenia was leading to high frequency of infection. This is not true anymore, luckily, with the novel therapies. But if you look after the treatment, of course, there are virtually no adverse events. And this is something that we are really keen on achieving, and of course, all patients would be happy. So how can we improve on the fixed duration? We can, for the simple reason that, again, as I showed you, we have a shorter efficacy in patients with p53 aberration, maybe also a little bit short in patients with unmutated immunoglobulin genes. And then we actually don't know if and when we can retreat the patient with the same combination, because this would be another advantage of fixed duration treatment. So other combinations have been developed, again, including venetoclax plus something else, and the something else is BTK inhibitor. So we try to combine the best drugs that we have in our armamentarium, and we did so in the Captivate study, where we used ibrutinib for 3 months to debulk the patient so that we can then introduce more potent drug like venetoclax together with ibrutinib for 12 cycles. So for 1 year, 15 months total. And we had a cohort of patients that had been treated with the fixed duration treatment. So at the end of the 15 months, everybody stopped. And what we have shown here, it is that indeed you can just look at the plot here on the right side. Patients with unmutated immunoglobulin genes in purple have a progression-free survival that is identical to all other patients. And it is almost 90% at 3 years. Patients with deletion 17p and p53 mutation, they are doing very well. So 80% of the patients at 3 years are free of progression, but they tend to progress a little bit earlier. So again, maybe the fixed duration, this type of fixed duration, maybe 1 year is not enough for these patients. So we should probably, and there are studies now to try to find maybe more prolonged therapies in order to achieve more durable response. The same combination has been tested in the GLOW study, where ibrutinib and ibrutinib plus venetoclax has been compared to chlorambucil plus obinutuzumab, so immunochemotherapy. And this is in particular interesting because the Captivate study was a study for young patients. This is a study for elderly patients, and it works also here very well. So it's 3.5 years, 3/4 of the patients are still responding to this combination. In terms of adverse events, when we combine drugs, of course, we expect a little bit more adverse events, at least at the beginning. For the young patient in the Captivate study, we have mainly diarrhea, meaning that diarrhea is an adverse event for both venetoclax and ibrutinib. When we combine, we have indeed 60% of patients having diarrhea, virtually all grade 1 and 2, so lower grade, lower severity, but still this is something that one has to know before starting therapy. In the elderly patient, situation is a little bit more different. Indeed, we have neutropenia in grade 3 neutropenia, so severe neutropenia, the decrease of white blood cell count, but also the good white cells, so the one that protect us from the infection. 1/3 of the patient will have it, and 17% of patients might indeed develop infection, when indeed among the young patients is half of them. So it is, we can say that it's better tolerated in the young population. The issue is that, as I mentioned here, we are using again a fixed duration treatment. So the length of treatment is equal to everyone, regardless the response, while instead we could use the assessment of minimal residual disease to really decide when to stop the treatment or if to continue treatment. So there are techniques now, exam tests that can be easily done, also in few minutes, to see how deep the response has been. So how we were able to achieve what we call minimal residual disease, or even better, measurable residual disease. So if we can still see disease or if we cannot. It doesn't mean that the patient is cured, but it means that we are very likely on the path to cure, because if we don't see any cell anymore, of course, it depends on the resolution of our test, but it's very promising that we might achieve much longer responses. I just want to summarize. A number of studies have been presented at the ASH Congress in December. And this is very important because they are paving the path to the future research in the next years. Because what it shows, and here I'm just summarizing everything in the one slide from the GLOW study, where we look at patients who achieve undetectable MRD and they carried mutated immunoglobulin genes, which is a feature of good CLL, as we say, with a good prognosis. And these patients, the patient with mutated immunoglobulin genes, they have a very prolonged response, regardless the fact that they achieve undetectable MRD or not. So even in patients where you still see disease, still these patients, if they have mutated immunoglobulin genes, they tend to have a very prolonged response. And we already know that this disease is much more indolent, is much more easily controlled. Even with immunochemotherapy, we could have very long responses. When we look at patients with unmutated immunoglobulin genes that tend to have a more aggressive disease, then there is a difference based on the level of minimal residual disease. So those who reach undetectable MRD, then they have a progression-free survival, a response that is as durable as patients with mutated immunoglobulin genes. So 90% of the patients at 2 years will still be responding. On the contrary, patients who have unmutated immunoglobulin genes and did not achieve undetectable MRD, then they tend to progress, and only 2/3 of the patients will be responding at 2 years of follow-up. So what we are now planning, we and others, is really to intensify the treatment of these patients and maybe add an extra year or 2 extra years to these patients based on the level of MRD. So we can identify those who did not optimally respond to the treatment that we applied, and then we can apply probably more treatment. And this has been already studied by us in another cohort of the Captivate study, where patients at the end of the treatment of combination between ibrutinib and venetoclax has been assessed for the minimal residual disease, and those who achieved undetectable MRD were then also randomized to continue treatment or stop the treatment with placebo, and those who did not achieve undetectable MRD, they were intensified with additional treatment. And just show you here, presented at ASH in 2022, that the patient who achieved undetectable MRD and stopped the treatment, they do as good as those who continue ibrutinib. So these are the patients where probably we can intensify, so decrease the intensity of treatment, decrease the quantity of treatment, because they already achieved a very good response. And so with that, I concluded. Just remind you that this is an evolving field. Every year we are learning something new, always something positive for our patient. And in particular, don't expect to have a one-size-fits-all treatment. I think that we will still benefit, many patients will still benefit from continuous treatment, which is much easier to give, few pills, oral, to a patient who doesn't need to come for many tests to the hospital. It doesn't need to come frequently to the hospital. He can take the pills and go far from the hospital, wherever they live. On the other side, we tend to move towards fixed duration treatment, because that would, of course, decrease the quantity of the adverse events, the cost, and in particular, thinking about the young patient, where indeed we have to probably be more cautious because they have much longer lifespan naturally in front of them. So we have really to play well all the different cards and try to think about how we can prolong also the responding second, third, and fourth line. Because again, these are patients who might have 30 years of life expectation, and where the 10 years that we can achieve with continuous treatment are definitely not enough. And depending on different features, we have really to decide the best treatment for each patient. So it's not only the genetic of the disease. So I spoke a lot about P53 mutated or unmutated immunoglobulin genes. These are still important in the era of chemo-free treatment. So as patients, always remember to ask for those tests to your doctors before starting any treatment. We have to know the patient. We have to know the comorbidities. We have to know which other drugs the patient is taking in order to avoid interference between interactions between the different drugs. We have to know the different drugs, what you can expect in terms of adverse events. One patient can be better with one than the other therapy. And at the end of the day, it's becoming more and more and more important. Patient preference, again, as I said, there are logistics issues. There are some patients who are happy to come for 6 months to the hospital to get infusion of antibodies, to do the ramp up with the BCL2 inhibitors, or some others who just prefer to take the pill every day and don't show to the hospital too often. So this is definitely a personal decision. That's why the patient should be much more involved in the decision about the treatment. Very quickly, I just want to remind you, this is we are in the COVID period. This is a study that the ERIC, the European Research Initiative on CLL, presented thanks to Andrea Visentin. I just want to remind you, we studied the effect of viral infection during different waves. And the good news is that patients are more protected now. And indeed, as you can see in the first wave, 30% of the patients with severe COVID, patients with CLL, were dying of COVID, with now only 15% of the patients. So we have been able to improve in terms of treatment, because now we have treatments in terms of vaccination because we have vaccination, and in terms also of protection of our patients. But just remember only one thing: life is starting again. We discussed this long. Patients are more protected. There are ways how to be protected, but we have to remember the patients with CLL still have a higher risk of poor outcome if they get severe COVID. So we have to do our best whenever we have a symptom leading to COVID, or whenever we are positive for COVID, we have to be treated immediately with antiviral or antibodies, depending what works, in order to not to allow the disease to become severe. With that, I thank you all. Thank you for your attention. I'm happy to discuss further the development of CLL.
Paolo, thank you. Wow. It's when you look at the picture of what's happening in CLL now, and I can imagine for many on the call, regardless of where you are in your journey, it can be quite confusing. There's going to be a couple of questions that are going to come in to ask for a bit of explanation about MRD and about unmutated, mutated IGVH, just so we can, because we use that term a lot and people might want that explaining. But before we do that, Brian, I've just wondered, as a long-term survivor, if that's the right word, CLL patient, who's been through the mill from the early days right the way to you are now, I'm just wondering, as an advocate and as an experienced patient, and I'm going to ask the question because I've seen a lot of questions for people that are on watch and wait. Sounds as if they might be a stable watch and wait, others untreated, some about to start a treatment journey, some maybe in the relapse setting and maybe about to start further treatments. As an advocate, what's your take on the landscape at the moment? And from Paolo's terrific talk, thank you, Paolo. You covered so much ground there, and I'm going to be going back and back to these slides. They are not just fascinating; they're quite exciting. But Brian, what's your take?
Yeah, Paolo, thank you very much for this overview. What when I was diagnosed in 2005, there were no therapies that were shown to even prolong life, and there was no really good options. And if you had these bad prognostic predictive markers like TP53 or 17p, your outcome, and I did have those markers, was really very dismal. So I watched this incredible evolution, and you were bringing us up to date on that. And at the CLL Society, we say that there's never a good time to be diagnosed with CLL, but there's never been a better time, except maybe tomorrow, because things keep just getting better and better. And I keep saying, well, I want to see what the next generation shows. I want to see what the bispecifics show. I want to see what the degraders show. I mean, there's just so many new exciting things. So I thank you for that incredible overview. Before we get to the specific questions, I do have one general question I would love you to answer. And despite all this progress, CLL remains incurable for the vast majority. There are some exceptions, but do you see, as a researcher who's got their finger on the pulse of all the research going on around the world, do you think there's a time you can look your patients in the eye and say, you're gonna, not just that you're gonna live normally, you're gonna have the same lifespan, I'm gonna manage it. Do you think there's ever gonna be a time to say to someone, I can cure your CLL with this combination, with this? Do you see that coming as a researcher?
I don't know if I see it coming. Definitely, we are working towards that. And I might say that I probably will not see that because we will need more than 10 years, probably 15 years before we can say you are cured, because again, we know the CLL is indolent in general. It takes years to come and it takes years also to relapse. So nowadays, for example, we have very deep responses with the combination between BCL2 and BTK inhibitors. So how long do we need before we can be really sure that nobody of those who maintain a response for 10 years are relapsing or not? So we do see, for example, with FCR, fludarabine, cyclophosphamide, and rituximab, the chemoimmunotherapy, we were able to achieve a long-term control of disease in mutated patients with mutated immunoglobulin genes. And this lasted more than 10 years. Unfortunately, some after 12, 13 years, they might relapse. Again, the disease is very indolent. It's coming very slowly. Probably they don't need another treatment for many years again. And again, after 12 years, the patient is 12 years older. So, you know, that's also reassuring. So it's very difficult. I think that we have no way to know immediately if you are cured or not. That's the only problem. So we need still a long follow-up. But definitely, I hope and I see that many more patients will stay off therapy for longer time. So I think that the future will be, in most cases, of a fixed duration or a time-limited treatment, let's say.
Thank you both. That maybe I could continue that question, but changing that more to management rather than cure, because what I picked up from your talk there was the use of MRD-directed therapy, delivery of therapy, that we seem to have come full circle when we go back to the chemoimmunotherapy days, which unfortunately is still the case in low and middle income countries. That's another topic that maybe we can talk about, but the MRD driven therapy wasn't quite available. You had to take the maximum dose to achieve a theoretical minimal amount of disease in your blood to get as long a remission. And I was just listening to your talk there that we're getting closer to a personalized approach, which I see as an advocate, it's really important to maybe explore a topic as how do we help patients to communicate or be able to communicate in their healthcare matters, because that seems to be really important now to be able to understand the pros and cons of different treatment. But I was also looking at is a management, because when I was diagnosed, and Brian, you were diagnosed before me, I think I was diagnosed 13 years ago, CLL was definitely not curable, and it was definitely you were told it wasn't manageable. So rather than the cure, do you now, how soon do you see CLL being truly manageable? Is that a different question?
I think that nowadays we can manage CLL. And again, in the past, in the era of immunochemotherapy, it was much more difficult to manage because we had patients who did not respond. So the patient with P53 aberration. So there we were not able to manage. Definitely, it was 0%. Second, the drug itself, the therapies in the era of immunochemotherapy, sometimes they were not well tolerated. So we were not able to manage, even if in a patient who had a more indolent disease, still, if we were not able to go through all 6 cycles, we knew that we could not manage properly the disease.
Yeah.
So here definitely is completely another picture, because most of our patients tolerate very well, if not all of them. We can find always a drug that can be well tolerated when we talk about chemo-free treatment. So this is not an issue anymore, or it's not as great as it was in the era of immunochemotherapy. And second, we have effective therapies even for the patient with P53 aberration. So I think that nowadays we can manage. The question is really how long we can manage. So definitely, as I said, we cannot cure all, but we can definitely provide many more years of control, but we cannot cure everyone. We cannot eliminate the disease in every patient. And I saw many questions asking about chemoimmunotherapy. As you mentioned, it's an issue of access. In the perfect world where everyone has access, I really don't see as a physician any more reason to use immunochemotherapy because of the toxicity, because of the long-term toxicity, acute myeloid leukemias, MDS that can arise later on as an effect of a consequence of the chemotherapy. And in particular, as I always say to my patients, with immunochemotherapy, you have to go through 6 months of hell, as we say, of difficulties before you can see the results. While instead with the novel therapies, within few days, few weeks, the patient feels better, sees the disease disappearing immediately. So also psychologically, it's much more effective. So I think this is the reason why, hopefully, with proper access to everyone, immunochemotherapy will be eliminated. Of course, where there is no access, in some patients, like patients with mutated immunoglobulin genes, immunochemotherapy is still a good option. For patients with unmutated immunoglobulin genes, is the only option that one can use. With patients with P53 aberration, that in that case, it should be immunochemotherapy should be always avoided because it's not providing any result. It's only providing toxicity.
Thank you, Paolo. I realize that we haven't really got a lot of time because you've been very thorough in your talks, but there's a couple of interesting questions, and I'm curious about them. Somebody's actually asked the questions in terms of outcomes between male and female patients. Are there any difference in clinical studies in outcomes between men and women? I know there's more propensity for men to have CLL than women, but I've never don't know the answer to that one.
That's a very good question. I have to admit how ignorant we are. And in this period of gender balance in every field, we should also apply to CLL studies. And we know, I can tell you that we know that from mouse studies, we always observe the difference between female and male, with female having a better outcome. And at the end of the day, we always try to either have female or male to have consistent experiments, and we never studied, we and others never studied deepen this information. But we have definitely to include that piece of information also in the analysis of our studies, where you don't really see that. We always stratify by age, by genetic features, and so on and so forth, and never by gender. But that's absolutely a well-taken point. I probably should also say something about minimal residual disease, where indeed.
Well, I was going to lead on to that.
I might created some confusion.
Well, there is two, and it's really difficult ones. There's the classic. We've always had to do that. What are unmutated and mutated immunoglobulins? What does that mean? And what is minimal residual disease? And what does undetectable mean? And why is it important?
Yes. So mutated and unmutated is a very confusing subject, because we typically learn from all oncology tumors, leukemias, that when a gene is mutated, it's bad, okay? And there are genes that are mutated and drive the cancer growth and the cancer progression. This is true. This is the same thing that happens with P53. When it is mutated, it's a bad thing. In the case of immunoglobulin genes, which are a structural feature of the leukemic cells, being mutated is actually a positive fact, because it is associated with a more indolent, a less progressive disease. And this is because it's not, immunoglobulin is not a regular gene, but is the receptor that the cell uses to recognize antigens, bacteria, virus, or whatever comes into the body. And therefore, when it's mutated, it works much better, and it tends also to slow the growth of the cell. While instead, when it is unmutated, then it is associated with a more aggressive disease. So that's why the unmutated patients, so the patient with unmutated immunoglobulin genes, are those who have a higher risk compared to those who have mutated immunoglobulin genes. Always remember, ask for this information. Not a diagnosis, you don't need, but at the time of starting treatment. For the minimal residual disease, it is very confusing, even among doctors, because it's the definition. So we say minimal residual disease or undetectable minimal residual disease. It means that we are not able to detect. It's very practical. We are not able to detect any more disease. So 10 years ago, that meant that we were not able to see any disease using the CT scan, using the white blood cell count. That was the maximum level we were able to achieve. Nowadays, we have a much more sophisticated technique where we can see if there is, as someone wrote also in the question, 1 cell out of 10,000, which is 10 to the minus 4 for those who were asking, 1 in 100,000, which is 10 to the minus 5, 1 in 1 million, which is 10 to the minus 6. So when we say undetectable, we have always to ask, which technique are you using and which is the level of sensitivity of that particular technique? If I have a technique that is able to detect down to 1 cell per 10,000, then that the undetectable MRD level will be 10 to the minus 4. But still, you could have 1 cell out of 100,000, but the technique is not able to see it, simply as that. So if you use another technique, which is like next generation sequencing, now you can go down to 10 to the minus 6, so 1 cell in 1 million. So you can call undetectable MRD when you reach that level, so much deeper. But because I have a more sensitive method to see if there is still 1 cell or not in the body. Still, is 1 cell out of 1 million, we could go down to 1 cell out of 10 million. This is not possible to achieve, and probably will never be in the future, because you really need a lot of cells, so a lot of blood to analyze in a machine instead of staying in the body of the patient, so which is not good. So at a certain point, I think that it will be a certain limit below which we cannot go. Does this correlate with the cure or not? We don't know. Again, we need a lot of years to see. Definitely, it correlates with a slower regrowth of the tumor. So the lower we go, the longer it will take the tumor and the leukemia to come again and become apparent.
Let me just add from a patient's perspective that I like the language of measurable residual disease instead of minimal, because I think that's easier to understand. It's not that there isn't disease there. It's just that, is the disease measurable with the techniques? Can we find it or not find it? Because we do know that a lot of people reach undetectable, measurable residual disease, UMRD, but it comes back again. It's not a new cancer coming back. It's probably the exact same cancer, but it was driven so low that we couldn't find it. We couldn't measure it. And minimal has kind of a vague meaning that's less clear. So there's clearly some people who get to UMRD that are cured, but there's a lot that get to UMRD that aren't cured and the disease comes back again. So I think saying measurable makes it easier to understand.
Yeah, definitely. And then let's remember also another thing, which is always important to remember, is that the numbers we provide are always percentages out of a population. So we can always talk about a population. So out of a population who reaches undetectable MRD, it is less likely that the patient will relapse. But still, if we look at the single individual, as you very nicely put it, Brian, there could be someone who reaching exactly the same level of depth of response. Still, one will relapse and the other will not.
Thank you both. I mean, my take is that, okay, so we now have the opportunity for virtually all groups of patients to have a fixed treatment, a treatment of a fixed duration, if the majority should be able to tolerate, and have the opportunity to have a remission, a treatment-free holiday, if you want to call it that, or you could take a simple single tablet, multiple tablets for a maintenance type therapy where MRD is not important. There are many ways and they might be down to your health state, what's most important for you, or it could be patient preference. So I take from this, it's really important. The discussion between the doctor and the patient is becoming much more important. And what I was going to say, as advocates working for leukemia care, CLL advocates, if you want help in how to enter those discussions, knowledge is power. So you want to find how you can learn the information you need at that moment in time. And I just want to pass a question to you, Brian. Yeah, and maybe when we were diagnosed, and I know there's quite a few people early in their pathway here, not needing treatment. They might be stable on watch and wait. We were told in watch and wait, no point thinking about what you might need should you arrive at treatment, because by the time you get there, it's likely to be something different that's available now. So my question is a rhetorical one in the situation we are in now. What would you say to those that don't need treatment now or may need it in the future? When should they start? Because this a massive amount of information that we've just been shared by you, Paolo, is hard for doctors to understand. And if patients who don't need treatment yet, what's your advice with regards to how much learning and how patients should learn and when they should learn? Because I think that seems to be the most important part of being able to communicate with your doctor. You need to be able to be empowered to share in your healthcare discussions. But I just recall the obsession of a patient like myself, diagnosed early, wanting to know everything, when perhaps everything I'd learned by the time I came to treatment was no longer relevant. So what's the situation? We think of those early in their journey at the moment.
So a great question, and of course it's going to vary from person to person. Our general approach, CLL Society, is to say smart patients get smart care, and we think it's important to preload your knowledge. But for some patients, that preloading the knowledge might be with their caregiver, their carer. For some of them, they can outsource their anxiety and worry to their physician and let their physician or their healthcare team do most of that managing for them, because it is going to change. And what you know now, some of that will be proven wrong, and most of it will be advanced and better when you need treatment. And that's why this whole watch and wait area, which seems so counterintuitive, really works, because first, a significant percentage of patients, maybe a quarter of patients, will never ever need therapy. So why would you have therapy if you never need it? Because all therapies have adverse events associated with them. So you're not going to know that. You can't tell for certain based on your predictive and prognostic markers, because some people with bad markers do great for years and years. Markers, as Dr. Ghia said, predict for a population, not for the individual in front of you necessarily. So if you're never going to need treatment, why get treatment? And the other thing is that if you wait, as you said, Nick, the treatments just keep getting better and better. And finally, there's been no therapies that have been shown that make a difference by intervening early. Now, there are trials going on now that are looking for patients that are high risk. So people like that Paolo talked about with the TP53 mutation, 17p deletion, seeing if we intervene with those patients with some of the newer, more modern therapies, will that make a difference? And that's going to be very interesting to see how those data read out. But it's too early at this point, outside of a clinical trial, to recommend to people that they consider intervening early. But if you're interested in that question and you're high risk, there are trials available that are looking at exactly that question. So it just, from my personal, I'll tell you what I think about. I think about pushing it down the road, because I know that what Paolo's doing and what the docs around the countries are doing is getting better and better options for me when I need my next therapy. So pushing it down the road, so they say, yeah, now we know, I have another year of data on this, Brian. I can tell you this is a better choice for you. Oh, there's this new one that's even better. Let's go with that. I mean, this zanubrutinib data was pretty exciting. You got to take that into consideration. These combinations weren't even on the table a couple of years ago. So the longer you can wait, the better it gets.
Thank you, Brian, for that. And
yeah, and probably, if I may add something following what Brian said, I would suggest don't follow your anxiety. I mean, this disease is a typical disease where you are never late. You are always too early with the diagnosis, because you could have made the diagnosis even later and nobody would have been affected. Many times too early with the treatment because doctors are getting anxious, the patients are getting anxious, and so on and so forth. So never follow your anxiety, follow the science.
Thank you, Paolo. And to add to that, that when you do get there, even now, there are multiple options, and that's likely to improve. I guess we've overrun, and I just want to ask a question of you, Paolo. There are some questions outstanding. Are you okay if I field those to you offline, that maybe we can then answer those questions and I can field them back in everybody's in the feedback?
Okay, yes.
I've got a few slides to share at the moment, which is really around how advocates and what organisations are available outside of the UK to be able to support patients in matters like learning, shared decision-making, anxiety. If you bear with me a moment whilst I try and find my slides. I believe I have them up. There we are. So if I start with the organisation CLL Advocates Network, who Leukaemia Care have partnered with to share today's event. CLL Advocates Network is an organisation, a global organisation, a network of, and I can't see from the slide, and the numbers are growing increasingly around the globe, where supporting. A network of organisations supporting CLL patients around the globe. If you want information, as I pointed out earlier, that's relevant to your country, visit CLL Advocates Network, and you can use the resource centre there, which will share information and what services are available in different countries from different support organisations and who to contact. If you're having trouble with that, always drop somebody a line at CLL Advocates Network. I'm just going to skim through these slides because you can read what are on the slides, you can visit them later. As an advocate, if you're not already signed up for the CLL News, the CLL Matters newsletter, you can. I've mentioned the Global Resource Hub. We're about to publish some global surveys over the next 2 weeks, which you'll find very interesting. The most recent one is around disparities and differences in what support's available in different countries and recommendations and activities that CLL Advocates Network are working with other networks to help with supporting that. But if you want help with supporting or you're seeking information for your patients, please do get in touch with CLL Advocates. You can find everything you need at the on the website. For UK patients, obviously, information sources are provided by Leukaemia Care with webinars such as this, our regular newsletters, our magazine, podcasts, very active on social media, and a really extensive website with lots of information booklets. Support services, we provide a helpline on WhatsApp that's staffed by clinical nurse specialists and the support services team who are there to answer your questions. If you want any information whatsoever, if you want any support, you can always just call. Virtual support groups, we have a national network of local support groups, either disease-specific, CLL-specific. You can find these through the website. Welfare advice, very current in today's financial times. We have in the advocacy team a welfare advisor who can actually support with where we have grants available for those that are actually struggling financially because of their leukemia diagnosis. Our advocacy support worker can help you when it comes to, if you're trying to make decisions, if you're looking to be able to communicate with your healthcare workers in treatment, then the advocacy support team and our advocacy officer is there to help you with understanding those questions and how to arrive at those answers to be able to better communicate and learn what you need to with your healthcare provider. Online forums, Facebook groups, and a buddy scheme. There's a very extensive buddy scheme where you can get your one-to-one connections with peers who know what you're going through. We also provide for those anxiety and emotional challenges of a diagnosis, a counselling fund that's available to give you 6 sessions if counselling would actually help you with tackling your challenges in those areas. We're very active on Facebook on Facebook, Twitter, and Instagram. Here's the number to get in touch with Leukemia Care should you wish to do that. You can have these slides after. Just want to reiterate to everybody that this session is being recorded and will be made available to everybody that's attended. It will also be put up on the website. It's currently available on Facebook as we're now still live. And that's the full circle. So really what I'd like to do is just to thank our fantastic panelists today. Paolo, that was a terrific talk. You really have covered the ground there. And I'm certainly going to be revisiting. I've learned a few things today, every webinar. And I'd like to thank everybody from around the globe, our UK patients and our international advocates. I noticed there were some questions there today about what's available access-wise in the UK and different countries. I think from that point of view, you need to be able to talk to your local provider, talk to Leukemia Care if you're in the UK. I saw a couple of questions there about what's available on the NHS. Quite a lot of that list that Paolo described is, and obviously it varies from country to country, but that's something that you could probably find through CLL Advocates Network or your national provider. So I'd just like to part company with everybody. Brian, have you got a last word before we leave as a patient and a patient advocate and your thoughts of the world today in CLL?
Yeah, I guess my last word is that I am extremely optimistic, but the work isn't done. And our job as advocates is to push people like Dr. Ghia to continue that CLL is not a solved problem. We've made tremendous progress, but as he said, we still don't have therapies that are proven to be curative. And we still have groups of patients that don't respond well. We still have issues like Richter's transformation. We looked at that SARS-CoV-2 data, very much better, but still unacceptable mortality rates. We still don't have ways to reconstitute our immune system. So don't give on us. Don't give up on us. Continue to research, continue to push the limits, find ways to reconstitute our immune system, find ways to offer us better therapies for Richter's, find therapies that are potentially curative, because we're very grateful for what you've done. I'm extraordinarily grateful 18 years out when I'm supposed to live for a couple of years. I'm extraordinarily grateful, but the job isn't done and we need your help going forward.
Thank you very much, Paolo. Thank you for all of your hard work. I'll just offer a passing gift to other CLL patients. 13 years ago when I was diagnosed, my outlook didn't feel as good as it feels now 13 years on, and I'm in second line therapy, and I know full well that there are options ahead of me. So yeah, time is not your enemy. That's the parting guess. Take that time, use it to learn, talk to your doctors, testing. I know you'll always vouch for that one, Paolo. Thank you everybody for joining us, and apologies for overrunning. I don't know how we could have tried to pack so much into an hour. See you all soon. Thank you very much.